Hello, and welcome to our Kirk Humanitarian-sponsored symposium entitled Creating a Healthier Future, National Perspectives on the MMS Evidence Base, Policy Landscape, and Implementation Approaches. My name is Nola Martin, and I handle the communications for Sight and Life. If you're not familiar with Sight and Life, we are a global nutrition think tank supporting the introduction and scale-up of MMS. Through our technical expertise in demand creation, supply readiness, and policy change. As partner to Kirk Humanitarian, we are proud to bring you a curated symposium with a distinguished lineup of speakers to present the scientific evidence supporting MMS over iron folic acid alone, and explore the policy around the topic, paying special attention to the current and long-term impacts of COVID-19 pandemic, and then bringing an exciting discussion around a variety of implementation approaches. Before we begin, I would like to draw your attention to two important resources. First, I encourage you to watch another Kirk Humanitarian-sponsored symposium titled, What's Next for the MMS Movement? Tools and Implementation and Coordinating Action on MMS Programming. Secondly, we have an MMS topic page on the Connected Conference website, where you can find the information and all other important live plenary and chat sessions, in addition to important resources. Now, without further ado, let's get started with our programming. First, we will hear from Dr. Robert E. Black. Bob is a professor of international health at the Johns Hopkins Bloomberg School of Public Health. Trained in medicine, infectious diseases, and epidemiology, Bob has led research in vaccine trials, micronutrients, and other nutritional interventions, and is an advocate for developing policies intended to improve child health. His presentation will bring to light the global need for MMS and make the case for superiority of MMS to IFA.
I'm going to discuss today the impact of antenatal multiple micronutrient supplements, which I will refer to as MMS, on women's health and pregnancy outcomes. It's important to recognize the high prevalence of micronutrient deficiency in women of reproductive age around the world. These data come from national nutrition surveys that have assessed various vitamins and minerals in women of reproductive age. As you can see in the different regions, there are a number of micronutrients that have high prevalence of deficiency. This is not only iron as represented here by IDA or iron deficient anemia, and folic acid represented here by folate, where iron and folic acid are given during pregnancy, but also other vitamins and minerals such as zinc, iodine, vitamins D, B12, and vitamin A. So these deficiencies are important in the regions, especially in the low and middle income countries. And the deficiencies are largely, but not entirely, corrected by multiple micronutrient supplements during pregnancy. The information I'm going to show you on the effect of MMS versus iron and folic acid, or IFA, on the birth outcomes comes from a large number of randomized controlled trials. The first set is the Cochrane review updated in 2019 that evaluated these trials and selected birth outcomes. And the second set of information comes from an analysis of individual patient data. That is, the individual trial information for many women was collected, and this allowed more analysis, more outcomes, and more analysis of modification of those outcomes by various characteristics of the woman or the supplementation. The information from the Cochrane review is in the middle column, and it has only a few outcomes, and the information from the IPD meta-analysis is in the far right column, and I'll spend more time on that because it has more information, and also the Cochrane review and the IPD meta-analysis show quite similar results. For the IPD meta-analysis, the effect on small for gestational age, low birth weight, very low birth weight, preterm birth, and very preterm birth are all statistically significant. These are all meaningful outcomes. Preterm birth is the leading cause of death in children, neonates in the developing world, and especially important is the large effect on very preterm birth. The effect on small for gestational age or low birth weight these are also very important because this represents fetal malnutrition, and this relates to further risk of mortality after birth and poorer linear growth after birth as well. There's also an effect of MMS on stillbirths, which was statistically significant in the IPD meta-analysis. As I said, the IPD analysis could examine various modifications of the effect of MMS in comparison to IFA. So these represent in the column on all pregnant women the effects that I just showed in the previous slide, just expressed in a different way. So an 8% reduction due to MMS compared to IFA for stillbirths, for example. But what is notable here is that in the IPD analysis, women who were anemic at the time of supplementation had a larger effect on stillbirths and also a larger effect on low birth weight and on small for gestational age. Interestingly, they had a large effect on mortality in infants in the first 6 months of life as well, which was not found with all pregnant women. Underweight pregnant women who have a BMI of less than 18.5 kilograms per meter squared have similar effects, but except for preterm births, where they have a larger effect than seen for all pregnant women. So in conclusion, there is a clear superiority of antenatal MMS versus IFA. There's strong evidence, as I've said, for the reduction in stillbirths, low birth weight, small for gestational age, and preterm births. The interpretation of the effect modification is be best looked at in regard to populations, because it may be difficult to screen women who are anemic or who have underweight and only provide supplements to them. So the interpretation I would offer is that populations that have a high prevalence of anemia or of underweight in women will have a special benefit in regard to some of these outcomes. And that is, particularly anemic women would have a greater effect on stillbirths, low birth weight, small for gestational age than non-anemic women, and the reduction of deaths as well after the first 6 months after birth. So this is an important guide to where we might want to implement MMS in the areas in the countries where there's a very high prevalence of anemia. I didn't show the results for sake of time, but in these trials, they did not demonstrate any evidence of serious adverse effects with MMS versus IFA. Thank you.
Thank you, Bob, for your excellent presentation and dedication to the topic. Next, we will hear from Nisa Dalmia, a maternal nutrition specialist at UNICEF headquarters. Nisa has had a 20-year career at UNICEF, where she has led micronutrient programming in more than 24 countries. Her presentation will address how to interpret WHO guidelines around MMS in context of the COVID-19 pandemic.
In this presentation, I will provide an overview of global recommendations and guidelines to support the use of multiple micronutrient supplementation in pregnancy, including the context of COVID-19. Globally, 1 in 10 women are too thin and 1 in 3 women are anemic. And these are two conditions that have largely remained unchanged over the last 2 decades and continue to threaten the survival and well-being of millions of women in low and middle-income countries and are linked to the births of 20 million low birth weight babies annually. Moreover, with evidence-based interventions and supportive policies in place, there are missed opportunities to deliver essential nutrition services to pregnant women. Less than 2/3 of pregnant women are covered with 4 antenatal care contacts, and 1/3 of pregnant women receive the requisite iron and folic acid supplementation doses. The COVID-19 pandemic has exposed these system weaknesses and threatens to undermine country progress in nutrition. Such setbacks in access to quality diets, services, and coverage risk to exacerbate malnutrition among pregnant women and increase low birth weight, wasting, and stunting. UNICEF's latest reporting on the impacts of COVID-19 related service disruption shows that over 1/3 of reporting countries face setbacks in delivering nutrition services for pregnant women in the last quarter, and over 1/3 of these countries also reported a 10% or more drop in coverage. The previous presentation provided a review of the evidence which forms the basis for the updated WHO recommendations on the use of multiple micronutrient supplementation in pregnancy. The implementation of these recommendations offers an important opportunity to improve maternal diets, anemia, and low birth weight, and to revitalize nutrition services and care for women in pregnancy. This recently issued guidance recommends that MMS should be introduced in the context of research. So what does research mean? For countries interested in introducing MMS, this means introducing it as part of implementation research. Such implementation research should aim to proof test strategies to demonstrate equity, feasibility, acceptability, and sustainability of MMS in program settings, and to use this evidence to influence policy change, domestic resource allocation, national scale-up, and inform MMS introduction in other countries. The recommendation also considers the need for additional clinical research to strengthen the evidence base and to inform future recommendations, such as on the use of ultrasounds in early pregnancy to establish gestational age, additional assessments of maternal and perinatal outcomes, and longitudinal follow-up of infants whose mothers were supplemented in pregnancy. For those countries interested in introducing MMS, forthcoming guidance will allow decision makers to assess their readiness. Criteria for considering MMS introduction include where there's a need, where there are poor quality maternal diets, a high prevalence of micronutrient deficiencies, including anemia and high rates of low birth weight, where there's a commitment to introduce MMS as part of antenatal care and to test alternative delivery platforms, where capacities exist to support the transition to MMS, such as training for health and community workers to improve maternal micronutrient coverage and adherence, and where MMS introduction can be integrated into routine monitoring systems to measure who took it and what worked. And there's additional guidance to support country-level MMS introduction also forthcoming, and such guidance is on introducing MMS as part of implementation research, which includes roadmap for planning and additional analysis needed to introduce MMS. This guidance is based on WHO's implementation research recommendations and is based on the experiences in introducing MMS in countries over the last 2 years. Guidance on feasibility of local MMS production and procurement, and formative research, which is currently being tested in countries and forms the basis of presentations in part 2 of this symposia. And finally, guidance on essential nutrition actions needed to protect maternal diets, services, and practices to mitigate the secondary effects of COVID-19. Essential nutrition services for pregnant women include adaptations for continued access to nutrition care, access to markets offering nutritious foods, expanding the use of social protection programs to cover maternal nutrition needs, maintaining uninterrupted supplies of essential nutrition commodities, including the continuous access of these commodities for women, and the use of innovative communication strategies on healthy eating and food hygiene. And then finally, ensuring that there are measures to ensure routine monitoring of these services. Many of these recommendations have been adapted and are being implemented across countries. And as countries move beyond the response phase to recovering from COVID-19, there's also an urgent need to restore and build back systems to deliver essential nutrition services. This is an opportunity to reflect and to consider new interventions such as MMS and the strategies that are urgently needed to deliver these services to women to improve their well-being and that of their infants. I'd like to thank you for your attention and look forward to supporting your efforts to bring MMS to the field.
That was a great presentation, Nita. Thank you so much. Now we'll hear from Spencer Kurt. Spencer is an entrepreneur, a philanthropist, and managing director of Kirk Humanitarian. He founded Kirk Humanitarian in 2005 with the mission of improving maternal health around the world, focusing on the production and scalability of high quality and safe multiple micronutrient supplementation. Humanitarian is the leading manufacturer of MMS and donates all products directly to low and middle income country governments and NGO partners. Spencer's presentation will focus on the crisis of maternal undernutrition that was prevalent before the pandemic and may now face greater consequences.
I'm thrilled to be part of this discussion because I am passionate about the urgent need to address the enduring crisis of undernutrition of mothers and babies alike. In this presentation, I'll be providing some context on this crisis, both before and after the COVID-19 pandemic, and I'll provide some high-level overview of the role of MMS, which is an essential intervention that can save lives. I'd like to first provide an overview of the threats to food security and nutrition services that the COVID-19 pandemic have posed, which Nita has already touched upon. We are seeing the effects of COVID-19 ripple outward. They threaten to lead an entire generation of undernourished people around the world. Things driving this threat include job losses, especially in low and middle income countries, where most jobs cannot be done at home. Many jobs have been lost with no prospect of return. Also, food systems in these countries were already precarious and now are struggling to meet needs during the COVID-19 emergency. And as we're seeing in most parts of the world, health systems do not have adequate resources to care for COVID-19 patients. In response to the pandemic, the New York Academy of Sciences Technical Advisory Group put out a statement on the importance of prioritizing access to multiple micronutrient supplements, or MMS, for pregnant women. The thinking was that MMS would help mitigate the negative effects of an increased lack of access to quality nutrition during the pandemic. While I won't read out this statement in its entirety, I wanted to highlight the following segment. COVID-19 may increase the barriers to achieving a healthy diet with an adequate intake of micronutrients for pregnant women, who are often socioeconomically marginalized during emergencies. But as we know, this is not a new crisis for millions of pregnant women. Even before the pandemic, millions of women were suffering from acute malnutrition and anemia. And these women lived disproportionately in low and middle income countries. COVID-19 is exacerbating an ongoing emergency in which millions of women and babies don't get the nutrition they need just because of where they live. Multiple micronutrient supplements help address micronutrient deficiencies and provide essential nutrition that can't be accessed through diet alone during pregnancy. They contain 15 essential micronutrients for pregnant women, including iron and folic acid. But access to these nutrients is not universal. They are a standard component of antenatal care in North America and Europe. But most women in low and middle income countries don't receive MMS through existing antenatal care programs. As Dr. Black touched upon in his presentation, multiple studies have repeatedly shown that MMS is safe, more effective than IFA at preventing negative birth outcomes, affordable, and at just over $2 per pregnancy, it is a cost-effective intervention for countries to invest in. In 2020, Kirk Humanitarian, having produced 5.5 million bottles of a 180 count MMS, we have become the world's largest manufacturer of Unimap MMS, all of which we donate at no cost. We are producing MMS at cost parity with IFA, 1 cent per dose, not 2 cents, not 5 cents, 1 cent per dose. Having a superior product at the same cost as IFA means the time is now to transition from IFA to MMS. Every woman deserves the best prenatal supplements, regardless of geography. When it comes to undernutrition, the thought of what lies ahead in 2021 and beyond is sobering. The COVID-19 pandemic is taking a devastating toll worldwide, and especially in low and middle income countries. Poverty and undernutrition will be prevalent at rates much higher than before the pandemic unless we act now. It is clear that investing in MMS research and programming is essential as we look ahead and plan a brighter future for mothers and babies. The maternal undernutrition crisis has been an emergency for a long time. It's time we treat it like one now. Given how destabilizing COVID-19 has been, now is the time to ask the tough questions and make pivotal changes in what we prioritize and how. Every mother and child, regardless of where they live, should have the right to access the 15 micronutrients found in MMS. And with assurances of quality and safety and advances in affordability of multiple micronutrient supplements, good nutrition is now more within reach for all women. The need is high, and the proof is clear. The time to act is now. Thank you to the Micronutrient Forum, and to my fellow speakers, and to all of you for your time and interest in this important issue. Together, we can save millions of lives.
Thank you, Spencer. We appreciate your insightful perspective. I'm excited to now introduce Dr. Kristen Hurley of Johns Hopkins Bloomberg School of Public Health, Vitamin Angels. As the Senior Vice President for Nutrition at Vitamin Angels, Kristen oversees their long-term impact initiatives, including creating global demand for MMS. Kristen will be introducing a series of presentations on country approaches to MMS introduction. She will briefly discuss how to explore readiness and eventual scale-up.
My name is Kristen Hurley. I'm going to, we've all heard already in this symposium about some of the evidence related to multiple micronutrient supplements for pregnant women, along with some of the information about policies and guidance related to MMS, or multiple micronutrient supplements. But this session, we're going to learn about, we're going to hear from different countries some of their experiences related to their approaches to introducing and scaling up multiple micronutrient supplements for pregnant women. So there is basically this kind of generic model, or some people refer to it as a roadmap for exploring and introducing and scaling, new or novel public health nutrition interventions, such as multiple micronutrient supplements. And this is, again, a very generic approach, but it was informed by past efforts to introduce and scale new public health interventions. And it basically includes 3 phases or steps The first one is a preparatory and advisory phase that really focuses on fostering an enabling environment, focuses on awareness raising, advocacy, ensuring issues of supply and demand are addressed or at least thought about, and gaining consensus for the introduction and scale up of the intervention. And then you move into an actual introduction phase, which really focuses on figuring out how to most effectively introduce a new evidence-based nutrition intervention so it's impactful at scale. It often involves doing implementation research to do things to figure out how to increase demand, uptake, and even adherence of an intervention. And as well, while doing that, oftentimes there's need to think through and to advance procurement relationships, or procurement relationships. If the intervention, like multiple micronutrient supplements, involves a product or a commodity, work needs to be done to figure out how to advance procurement relationships or manufacturing capacity to ensure a long-term sustainable supply. And then those activities inform the ultimate scaling of the evidence-based nutrition intervention that really focuses on expanding the implementation coverage and use at a national level. And so this, this roadmap is really illustrative. It's very high level. It's not a definite, definitive template by all means. It's intended really to stimulate discussion and thought and planning, to help with the planning. The roadmap is also not country specific. It's, there's several, for example, there's several different multiple micronutrient supplementation distribution channels that can exist at a country level. There's the clinic and community-based ANC services offered by national governments or NGO health systems or some combination of the two that can be used to distribute MMS. But there's also, in some countries, kind of this social marketing system. There's private practices, there's retail pharmacies that can also be used to distribute MMS. And I think the final kind of consideration in thinking about approaches to introduce and scale is to remember that it's not, this activity is not simply just switching from one product to another, such as IFA, which is the current standard of care, to MMS. But the whole introduction of MMS also presents an opportunity to strengthen the current antenatal care services and also to improve maternal nutrition. So today, I'm delighted to introduce 5 different speakers who are going to really focus and talk about kind of their experiences, in-country experiences, and lessons learned around the pathway to introducing and scaling multiple micronutrient supplements. So we are going to hear from people from Haiti, from Bangladesh, and also from Tanzania. So we will start by hearing about Haiti's experience in terms of their approach to implementing multiple micronutrient supplements for pregnant women. So we'll hear from Dr. Jocelyn Marron-Pierre, who's the director of the Ministry of Public Health and Population, and also Dr. Minot Decius, who's the country director at Vitamin Angels.
Now we'll hear from Dr. Minot Decius, Vitamin Angels Haiti country advisor, and Dr. Jocelyn Marron-Pierre, director of Haiti's Food and Nutrition Program. Minot manages the Vitamin Angels products in Haiti to deliver essential micronutrients products. As a physician and a Master of Public Health degree, he brings with him a combined experience in clinical and public care with hospitals and NGOs. Jocelyn is trained as a physician, a pharmacist, and a nutritionist. And with over 40 years of experience in the field, she is truly the definition of an expert. Together, they will discuss Haiti's blended approach to MMS introduction and implementation during the pandemic.
Bonjour à tous. Good morning, everyone. Prior to starting with the presentation, let me thank the organizers for this opportunity which has been given to us to share with all of you our experiences with MMS in Haiti. It's also an honor for me to be part of this virtual symposium micronutrients, the 5th Global Conference on Micronutrients, which gathers people throughout the world despite of COVID-19 pandemic. Anemia is one of the biggest nutrition public health problems in Haiti. According to the national data, during the opportunity window, which is the most critical nutrition period in a child's life, 50% of pregnant women, 30% of lactating women, and 75% of children less than 23 months out of 61% of children less than 5 years suffer from anemia. In accordance with WHO recommendations for a positive pregnancy experience, the Ministry of Health has taken steps to introduce MMS in its national protocol and expand the program nationally in partnership with Vitamin Angels. To do so, we are conducting implementation research in order to inform the program scale-up. I invite Dr. Mino Dacius, who is the Vitamin Angel Director in Haiti, to talk about the implementation research.
In fact, in partnership, the Haitian Ministry of Public Health and Population, Vitamin Angels, Johns Hopkins Bloomberg School of Public Health, and a local NGO, the Haitian Health Foundation, we are conducting an implementation research to inform the scale-up of an MMS program in Haiti. One key component of this research is to develop and field test SBCC strategies and tools intended to support the uptake and adherence of MMS among pregnant women. The implementation research is actually described in the Silent Life Special Report on MMS. In terms of site selection, we chose 5 communes within the Grandas department. We selected that site because it has the second highest rate of anemia and has an existing antenatal care platform. We went through a very systematic process review. We sought guidance from Silent Life and utilized their 8-step process for developing, implementing, and evaluating new behavior change strategies and tools. To start with the process, we worked with key stakeholders in Haiti to develop the program goals and objectives. We convened a workshop with key government stakeholders to explore maternal nutrition, antenatal care, and implementation of an MMS program for pregnant women in Haiti. We set the objective of providing MMS to all pregnant women in Haiti, as well as to increase uptake and adherence to MMS. For the step 2 of the process, we use the socio-ecological model that provides the guidance for the basis of the formative research study design and the framing of the overall demonstration project. It provides a framework for understanding the multiple levels of influence on women's behaviors during pregnancy, including personal, interpersonal, community, health system, and policy. The step 3 of the process consists of a formative research. We conducted in-depth interviews and focus groups with women, influential family members, community leaders, and healthcare professionals. The objectives were to understand experiences and perceptions related to pregnancy, antenatal care, and prenatal supplementation, and to understand the barriers and enablers of ANC and prenatal supplement use and adherence. A 2-week acceptability trial was also conducted with pregnant women to examine the extent to which MMS was deemed suitable, satisfying, or attractive to them. As for the formative research findings, there were barriers and inhibitors to antenatal care and supplement use, considering the multiple levels of the socio-ecological model. Some key themes we found were related to the side effects of the supplements, fear of large baby and C-section, community beliefs, ANC access and quality, supplement access and quality, poverty. These are some of the quotes that represent the themes that I highlighted related to the barriers. For example, that pregnant woman in the commune of Jeremy who said, "My friends warned me about the negative effect of the multivitamins on the baby's weight, which could lead to C-section. They told me to take little from the package. If they gave me 30 pills, I should take 10. Regarding the inhibitors now, the themes were mainly related to family support, community awareness, trust in the health system, community channels, fear of anemia, ANC access and quality, supplement use, and quality. Here are some examples of quotes that highlighted those themes. For example, the pregnant woman in Bonbon who said she, referring to a pregnant woman, should take it, referring to the MMS, for anemia, so that her blood can speed up, to have more appetite, to have more strength to deliver a good baby. We also found several opportunities and challenges as regards to the healthcare system. They're about the role of the providers, the community, their responsibilities, their motivation. We found some key pinpoints in the relationship between the health providers and their communities. We're also informed on the functioning of the healthcare system, its dynamics, and its structure. Let's take, for instance, in regard to the opportunities at the healthcare system level, that quote from a husband in Mo who said, "If you follow the advice from the healthcare providers, everything will be all right." As we have completed these steps, it's become clear how important it is that the process be an iterative one, always allowing the insights gained from one step to inform the next. We started with a stakeholders workshop back in September 2018. We've completed 3 steps so far, as shown here. Now we're working with a local design agency to develop and field test SBCC strategies and tools and to strengthen the ANC system. We're also working with the Department of EPI from the Ministry of Health to conduct baseline survey before we implement the intervention and an inline survey right after the intervention. Now I turn it over again to Dr. Marwan, who will sum up with the current efforts of the Haitian government in these times of COVID-19.
Thank you, Dr. Mino. But you have to know, as we were going through the implementation research, COVID-19 pandemic it becomes harder for pregnant women to meet their nutritional needs. WHO and UNICEF then came out with new guidelines to implement nutrition activities in the context of COVID-19. The Ministry of Public Health and Population has decided to start expanding the program. Together with Vitamin Angels, we put in place a mechanism to distribute MMS and provide all necessary resources to the regional departments to operate an adequate supply chain management and effectively reduce pregnant women. So far, we have reached 6 out of 10 departments in the zone as we are progressing with the implementation research, which will further consolidate the scale-up of the program. Now, this is the time for us to acknowledge the Minister of Health and Population, the Haitian Health Foundation, John Hopkins Broomberg School of Public Health staff, Vitamin Angels, Sight and Life Foundation, Kirk Humanitarian Foundation, research participant. To all of them, we say thank you, merci beaucoup.
Thank you both for that presentation. Now we'll hear from Tuslan Udin from the social marketing company in Bangladesh. He is an experienced manager with a demonstrated record in designing, developing, and monitoring public health programs for over 25 years, and is currently the Chief Program of Operations at the social marketing company. Tuslan will discuss Bangladesh as a case study for MMS implementation and marketing.
Thank you, Nola, for introduction me. I am from social marketing company, and social marketing company is one of the largest social marketing program across the world. And social marketing company over the last 45 years working for the improvement of the health status of children, women, and families across the country. And now the situation, please go to the next slide. Now the situation, what is the situation about the nutrition of this country? So Bangladesh has the highest prevalence of low birth weight. It is 28%, and micronutrient deficiency is a major risk factor for this low birth weight. And it is not only for low birth, nutrition problem with pregnant mother, it is also women of reproductive age. For example, 40% women of reproductive age suffer from anemia and 57% suffer from zinc deficiency. Go to the next slide, please. So what is the implementing strategy? If we look back, our social marketing program in Bangladesh, we will be seeing that SMC popularized public health products and service through implementing social marketing techniques. And in this way, the significant contribution in public health issue over the last 4 decades, SMC made, for example, popularizing ORS, oral rehydration salt. Significantly, this oral rehydration salt reduced the children, the mortality of the children under 5 with diarrheal diseases. And for example, another success story is contraceptive prevalence rate. Contraceptive prevalence rate of the country is 62%, and 1/3 of the modern contraception is coming from social marketing company. And similar market strategy will be applied for popularize and increase use of MMS among the pregnant women through our program. Go to the next slide, please. And this, if we consider the implementation strategy, there is 2 major focus. One is B2B, which is business to business. That means our target audience here will be all the providers who will be playing critical role for the distribution and popularizing and counseling for the MMS. And business to consumers is who are really end user will be purchasing this product from our different network and their pharmacies. Then this MMS primarily will be distributed from our networks. We have 3 networks. I'll be telling it later that who are they, and their name is Pink Star Provider, Blue Star Provider, and Green Star Provider mostly. And also we will be targeting NGO outlet and other public health facilities for distributing MMS. And there is a technical advisory group, and this technical advisory group, the main role is to facilitate us and make the enable situation for implementing MMS. And If there is any regulatory barrier, they will be helping us to resolve that regulatory barrier. So go to the next slide, please. Right. If the previous one, the next one, yes. I mean, if we consider our four major network, just giving a brief information about the network. The Blue Star network is the one with 7,500 outlets, and they are mostly non-graduate medical practitioner and who are offering under our network public health services at the community level. And then the Green Star one is mostly drugstore. We have brought them under a network and provided the training to offer over the counter counseling services. And then the Pink Star is a network with OBGYN. They're a graduate doctor at least, and with the higher degree they have, and they're offering services for the pregnant women. And then the Gold Star is a rural woman entrepreneur creating demand in the rural community, and the number is 2,400. And uh, go to the next slide. So all of them will be engaged in offering services. If we narrate the marketing strategy, that is this conceptual framework narrate the whole things comprehensively. Our whole purpose is to increase the demand and increase the utilization of MMS. How we can do it? We can do it through the Blue Star provider. They will be generating through counseling and treatment process through prescription, and then they will be selling the product through their outlets. We will also use the digital platform. Pregnant women will be pregnant women will be the major. Please go back to pregnant women is our main stakeholder, and also their husband and mother-in-laws will be also instrumental to create awareness among them. And the product will be sold through other pharmacies as well, and other public and private sector graduate and non-graduate providers. We will be sensitize them, and we can engage them as well. So the whole thing will be done through a comprehensive promotional strategy, which include below the line and above the line, TVC, RDC, interpersonal communication, digital campaign, detailing card, planners. So everything, I mean, will be considered for promoting this MMS. Go to the next slide, please. And what is happening during the COVID situation? In fact, the COVID situation is not is a major issues at this point for us. Initially, for the first 3-4 months, it was a big issue then, and it was been challenge. The big challenge we faced to ensure our supply line. The country, across the country, through all Blue Star, Pink Star, Green Star, and Gold Star members. I mean, to ensure the supply to them, and also the other pharmacy and non-pharmacy outlets who are also selling our products. So it was very difficult for our sales force to ensure their safety, and then distribute the products through them. So, but now it is more or less normalized, and we are trying tirelessly trying to ensure the supply smoothly to all the retail outlets of this country. And we have also, for our Blue Star and Green Star providers, we distributed PPE for them so that they can continue offering their services, keeping themselves secured and protected. Another thing is there was I mean, there's another issue, I mean, which I can mention here. During the COVID time, I mean, we had to mobilize this program. And one of the thing is that we need time for organize the, for getting the approval from Director General of Drug Administration, and they periodically sit for reviewing this product and give approval. So that automatically, it take few months. So these few months we spent in that. So we can say that mobilization stage, since we are passing through mobilization stage, so that will not be too much difficult for us to cope up the whole things. And finally, the MMS will not be will be a problem for distribution. I mean, we are thinking that all the legal aspect will be completed and the product will be on board by February. And this time we are doing a lot of other works, I mean preparatory works, so that once the product is available, we can ensure the supply. The next slide. Perhaps that is the final slide for me, and I would like to thank everybody for your patience hearing.
Thank you for sharing your country perspective, Tuslim. I'm excited to turn to Sally Epivark from Tanzania Food and Nutrition Center. Sally will discuss Tanzania's government-led demonstration program.
Okay, thank you very much for this meeting. Special thanking Nola for the invitation. And I'm presenting on behalf of the Tanzania Food and Nutrition Center and UNICEF Tanzania. I'll be presenting on the project known as Improving Maternal and Adolescent Nutrition in Tanzania, in short forms known as Imani Project. As you can see, that's my name, Saul Pimak John, currently working with the Tanzania Food and Nutrition Center. Doing introduction on the background of the nutritional status of women 15 to 49 years in Tanzania. So as you can see, thinness, percentage of thinness among women of reproductive age is about 9.5%. Overweight or obese is ranging about 28.4%, and obese is 10%, while low stature is 2.8%, and the anemia among women of reproductive age is 44.8%, and the anemia among pregnant women is 57.1%. And the maternal mortality ratio is 556 per 100 live births. And this information is gathered from the Tanzania demographic, which was conducted in 2015. In the 10th nutritional status of women of reproductive age here in Tanzania, you can see that the prevalence of overweight has been increasing. When you look from has increasing throughout the of overweight has remained almost the same for quite some years. However, anemia among women aged 15 to 59 years has been, where you can see in 2005 it was 48%, 2010 it was 40%, and 2015 it was 45%. Now we see that there has been an increase in maternal mortality ratio in Tanzania. When you look available data, you'll be able to see that although maternal mortality rate has been decreasing, however, as a country, we are still having large numbers in such a way that we are not able to reach the health service target, where to reduce the maternal mortality ratio to 292 by 2021. Also, at the country, we are not going to reach the Sustainable Development Goal target of having only 70 maternal mortality rate. So we see that improved maternal nutrition interventions at scale can be instrumental to meet national and international targets to reduce maternal mortality. Here you can see the percentages of micronutrient deficiencies among women in Tanzania. So this data is old. It is from the Tanzania Demographic Survey 2010. However, there is no recent data on micronutrient deficiency. We are planning to collect new data in the coming Tanzania Demographic Health Survey so that we can have an updated information. Although data is quite old, but the micronutrient deficiency is still an issue, as you can see in this slide. We can see some of the percentages of key indicators influencing women's health and nutrition. For example, 23.4% of women having secondary or higher education, where 76.8% literacy adult female, and also 98% receive ANC from a skilled provider. However, majority of women by age based by the age 20. Also, 27% are teenage mothers. Overall, we can see that implementation is on track, where 80% impact targets met. However, not on track for the WHO health targets. Tanzania is heavily affected by the triple burden, where 1/3 of women aged 15 to 49 years are suffering from anemia. Then also 1/3 of women aged 15 to 49 years are obese or overweight, and the 1/3 of children are stunted. Also, overweight or obesity among women is the only form of malnutrition increasing in Tanzania and associated with diet-related non-communicable diseases and the high health care costs. Nutrition interventions for school age or adolescent are not prioritized. Also, schools are an important platform to reach high numbers of adolescents with nutrition interventions, but currently underused. Despite high food production in Tanzania, consumption of animal foods and micronutrient-rich foods is low among women and also you can see the policy environment is supporting maternal and adolescent health and nutrition agenda in Tanzania. We have different rational nature of project implementation. This project is the outcome of the midterm review of the National Multisectoral Nutritional Action Plan, which necessitated the need for a renewed approach to improving maternal and adolescent nutrition through the development of the evidence-based Imani program. So also global evidence on MMS and also food-based approaches. Scope: extended consultation with government partners and the other stakeholders resulted into the nature of the project implementation. This project is built through the theory of change, as you can see, where we have the strategic goal to improve maternal and adolescent nutrition in Tanzania, and also we have the 3 outcomes. Second, improve the system of maternal nutrition services. And third, strengthen the enabling environment for maternal and adolescent nutrition. And also we have a number of outputs for each of the outcomes as you can see. The program overview, improving maternal and adolescent nutrition through vital interventions in Tanzania, is built through different platforms. So we have adolescent nutrition, maternal nutrition, and also the enabling environment. For adolescent nutrition, we have human resources, commodities, and also delivery platforms. The same for maternal nutrition, and then for enabling environment, we have nutrition governance and also information system. So, we have also the organization structure of the IMAN program. However, we are still working to review on this. IMAN project is a consortium where different institutes and the organizations are working together, as you can see, together with the roles. So we have the Ministry of Health, which is providing the technical leadership, policy and guidelines development. But we have the Tanzania Food and Nutrition Center, which is providing overall coordination, micronutrient survey in their region, and also other institutions, as you can see, including the Certain Life Foundation and also the pharmaceutical unit of the Ministry of Health. Then the project will enhance food systems to improve women, children, and adolescents by access to highly nutritious foods. So it will generate new evidence on bottlenecks impeding access to nutritious food, strengthen counseling on maternal, children, and adolescents, enhance and scale up food fortification at all levels, strengthen synergies between existing large-scale nutrition programs, such as stunting reduction programs and also agriculture programs. The strengthening synergies with the other key sectors and the private sector, such as WASH, where it will build synergies with national water, sanitation, and hygiene programs, working both on improved infrastructures and behavior change, also social protection, to strengthen synergies with national programs, including health insurance and also TASAF, to provide special support to most vulnerable households or those with pregnant women and adolescents. Also education, to strengthen school health and nutrition programs targeting adolescents. Also business, to explore opportunities to improve food fortification and the national production of nutrition commodities. So this project is it will build a public-private partnership. For example, the work by the site and life food assessment, where it had the objective to determine comparative advantage for local production of nutrition commodities versus importation, document in country capacity to procure ingredients and produce nutrition commodities locally, also provide guidance on actions needed to ensure competitive and affordable sources of MMS supply, assess the impact of shifting from import to local production of MMS and vice versa. So the approach includes desk research, market assessment, production assessment, regulation, and also policy assessment. So we can say that Tanzania has greater potential for local production of nutrition commodities to meet the local as well as the regional market. So delivery platforms such as health facilities, schools, community, and also outreach. So the implementation update and the next steps. So phase one included field work, analysis, and reporting. We had a number of field activities such as regional nutrition survey, including the micronutrient survey among pregnant women attending antenatal clinic in Mbeya. This has been completed. We are now doing the report for this survey. Then also, we are having the baseline analysis on compliance with antenatal clinic guidelines and IFAS intake. This is also has been done. We are waiting for the results on this study. Then we will be doing the formative assessment of adolescent school health and nutrition, barrier analysis on the provision of maternal and adolescent nutrition services, and also ethnomedical study. Afterwards, phase 2 will involve the dissemination of results. We develop a dissemination package. Will involve designing implementation research, and then phase 4 will involve implementation and dissemination. This will be informed by phase 3. Then phase 5, this will inform the scale up of the project. Thank you very much.
Thank you so much, Sally. And now, delivering the closing remarks is my colleague, Dr. Klaus Kramer. However, before I hand it over to Klaus, I would once again like to encourage all of you to visit the MMS topic page on the Connected website. Among many other resources, there you will find a special report focusing on MMS and pregnancy. This was launched by Sight and Life in April of this year, and each of our presenters have contributed to this report, and you can read all about the evidence, experiences, and resources in greater detail. Now back to Klaus. He is the Managing Director of Sight and Life Foundation, a nutrition think tank headquartered in Switzerland. And he's also an adjunct associate professor in the Department of International Health of Johns Hopkins Bloomberg School of Health. He is a passionate biologist by training and brings a wealth of experience and expertise to the topic. He diligently works to make an enabling environment for MMS and looking to bring significant change for the generations to come.
Thank you, Nola, for your very kind introduction. I'd like to extend my thanks to all of our speakers for taking the time to share their expertise. As most of our speakers discussed during their presentations, the future of maternal and newborn nutrition is dire. Tens of millions of women suffer from undernutrition every year, and the COVID-19 pandemic is exacerbating this crisis. Learning from country experiences about the multiple micronutrient supplement programs is crucial as we look ahead. The insights from Haiti, Bangladesh, and Tanzania were illuminating and illustrate the many different ways national leaders can approach MMS introduction based on their country context. There are several ways that the nutrition and health communities can and should come together to increase resources, provide technical support, and change the policy landscape for implementing MMS programs. First, with the recently updated guidelines, the World Health Organization now recommends MMS in the context of rigorous implementation research. This is a critical step to accelerate MMS policies at the national level. Second, we must increase investments in MMS programs to catalyze a ready-to-implement solution, including production, improved supply chains, innovative delivery systems, and implementation research to create demand. This will require that the public and the private sector and even unusual partners come together. Third, documenting lessons learned and evaluating programs are key to not only guide course corrections and assess impact, but also to support the policy dialogue on MMS by demonstrating the importance and the feasibility of MMS programs. Thank you so much for joining us today. We hope you learned something useful. And thank you to Kirk Humanitarian for sponsoring this session and the Micronutrient Forum for bringing us all together to connect on improving life through micronutrient nutrition. Thank you.